We're moving forward into looking at the EKGs. We're going to go through 2 chapters, looking at how to interpret in chapter 5 and going into the basic sinus rhythm in chapter 6. So some of the things that we're going to begin with chapter 5 is looking at we call systematic, like being organized and what you're looking at in the EKGs, describing the differences between a rhythm strip versus the 12 lead, understanding the difference between normal and abnormal rhythms, and then following the same process in the systematic with looking at just a static strip or a waveform on screen, trying to have a little bit of a kind of a process. So we're going to divide these up into steps. So step 1 is to determine how regular the rhythm is, the rate and the rhythm. So we use this called the tick mark. So we start all the way to the far left at the top of where all of the R waves, right, the spikes of the R waves, and we make small tick marks above the first and second R waves. So we're move the paper and looking at the first tick mark and over for the next R wave. So you're looking for a little bit of consistency in those tick marks along the top. So the small tick mark falling on the left of the second R wave, and then another small tick mark falling to the right of this is the longest. So 0.12 seconds or 3 small boxes or more in variation between those R to R's would be an irregular rhythm. So what I mean by that is, here's what we say, kind of the first 2 R waves. So we've got a tick mark, right? So where the R wave falls, you're looking at the timing between the variation. So when we're in class, it's a little easier than doing it remote, but you're looking kind of, I always say, kind of eyeballing that the spikes, the R to R intervals, and looking for any of that irregularity. The second step is what we've already done in the last lecture, where we look at heart rate calculation. So can you determine the heart rate? So one method is that 1500 method, right? You count those baby boxes between one R wave and the second R wave, right? So just how many little boxes, and then it's the kind of constant, the division is by 1500. The dark line method, I call that the triplet method. That's when you memorize and you count backwards in this kind of method of 300, 150, 100. And how we begin this is you happen to find one R wave that lands on a solid line. Remember, we find the R wave that lands on a solid line and you count backwards. So the first, what are you counting backwards? You're counting backwards on the lines on the EKG paper. So you count every bold box as 300, the next bold box would be 150, the next bold box would be 100, and you just keep counting until you see the very next spike, the next R wave on the paper. We call that the triplet method, or the dark line method is the other one it's commonly called. And then the third one we talked about in the last lecture was what we do when we have an irregular rhythm. So an example of an irregular rhythm. So the other 2 methods, the 1500 and the dark line method, we use with what we call NSR, normal sinus rhythm. We are not going to use them when we have an irregular rhythm. For an irregular rhythm, we're going to do the 6-second strip. So if we haven't really looked at irregular rhythms yet, but an example that I gave you last week was AFib. So if you have AFib, you have irregular R waves. So now you're going to take a look at a 6-second strip. Remember, the paper is timed, and you're going to count how many R to R intervals, and multiply by 10. You could do the same thing with a 3-second strip, and you're looking at those R to R waves. It's very similar to counting your own pulse, right? On the pulse on your wrist, you're feeling that kind of metronome of that beat of your heart rate, and you're counting those beats, and you multiply by 10, usually, if you're doing a 6-second. Anyways, so the irregular method, again, is used for irregular rhythms. So step 2 is, what is the heart rate? Step 3 is we want to take a look at the P wave. So we want to look at how many P waves, what's the shape of the P wave, are the P waves irregular, do you have more than one P wave? P waves are letting us know what's going on in the atrium. So ideally, you're looking for a P wave to be upright. Every P wave should be followed by a QRS. You're looking for the P waves to be of similar size throughout. If the P wave is abnormal, meaning it's an odd shape, it's happening not in a consistent manner, we would use the word sinus or ectopic or ectopy. It means that it's not being paced from the SA node, and one of the other cardiac cells is getting excited and causing that ectopic, excited beat to contract the atriums. An early contracted atrium means the P wave is going to be a different shape, different morphology, means different size, have a different timing to it. If the P wave is coming from the same SA node, it's always going to look the same, right? That's what we want. The P waves always look the same. But if it's abnormal, right, shape, timing, size, it would be an ectopic, right? It means a cell somewhere in that atrium got prematurely excited and caused a contraction, and that means that it contracted early on the paper and it has a different size, a different shape, because it's coming from a different cell. The PR interval is a really common one, right? So from the beginning of the P wave to the beginning of the R wave, you want to count those boxes. And the PR interval to be healthy and so-called normal, right, for NSR, normal sinus rhythm, we want the PR interval to be less than 0.2 seconds. So you measure from the beginning of the P to the beginning of the QRS, you count those little boxes, right? Each little box is 0.04. So you want the PR interval to be less 0.20 or less. And that's an important thing. Later on in another chapter, we're going to look at why is the PR interval so important. So pretty much it's the communication from up in the atrium, the SA node, moving down to the AV node, and then eventually from there it'll move down to the ventricle. So if there's a conduction problem, a delay in the conduction from the SA to the AV to his bundle into the ventricles, we are going to be able to tell there's a conduction problem because the numbers, the timing is going to be off. Too much information too soon. PR interval. What is the PR interval? P to the QRS. The fifth step is what is going on in the QRS. So this should be skinny. It's tall, but it's going to be skinny. The width, the duration, the seconds of the QRS should be 0.12 or less, right? So 2.5 small boxes or less. So to count the QRS, we begin at the beginning of the QRS to the end of the QRS. We count those boxes, and for it to be a good looking QRS duration, it's going to be less than 0.12, which is very skinny. Q waves. Okay, so Q waves are an interesting thing. They're important, but it's also important to state that in healthy people, we often don't even see a Q wave. So a Q wave, that is the word significant. A significant Q wave that shouldn't be there, right? So significant Q waves are big Q waves. We in healthy people don't see this. So a Q wave in the anterior inferior leads is what we want to look at, or a Q wave that is greater than 2 millimeters that's in the lateral leads. And we'll look more at Q waves as we move through, but you just want to note with your eyes in this very systematic way of looking at an EKG is there a Q wave? Yes, no. The seventh step is what's going on with the ST segment. Remember I used the word isoelectric, flat, parallel, flat line, the ST segment. However, if the ST segment is not isoelectric, it could be, we want to look at, is it undergoing depression? Is it undergoing elevation? That all means different stuff. So if we're looking for a healthy, normal sinus rhythm, we want it to be isoelectric. After the ST segment, there should be a T wave, right? It should be following the direction of the QRS. So T waves are going to be usually positive, right? So you're looking at the size of the T wave, the length of the T wave. Other things that we would look at would be axis. Remember we looked at axis deviation in the last lecture, right? So you look at lead 1 and AVF and you're looking for what direction the depolarization is moving in, right? It should be moving in that normal axis deviation. So that would mean your lead 1, all the waves are positive on lead 1 and AVF are positive, and it puts you in that normal quadrant. If you don't have positive in lead 1, then we'd want to look at, is it right axis deviation? Is it left axis deviation? So axis is another one. The other thing is the word ischemia, lack of blood flow, or myocardial infarction. So ischemia and infarct. To tell if someone is undergoing ischemia or infarct, we're looking at, is there a Q wave? We're looking at what's going on with the ST segment. Is it isoelectric or not? We're looking for changes in different leads, which we haven't gotten there yet, but the different leads, anterior, inferior, lateral. So chapter 5 is just going through these steps that may not make sense yet to you because we haven't learned each of these steps, but it begins to have a way of how you begin organizing the questions you're asking. What is the heart rate? What is the P wave? What's going on with the QRS? What's going on with the PR interval? What's going on with the ST segment? Is axis normal? So we want to be able to slowly over the next few weeks go through these questions so we can determine, are we what we call NSR, normal sinus rhythm? So that brings us to rhythms, right? So sinus rhythm, chapter 6. So I want you to look at what is normal sinus rhythm, what happens with bradycardia, tachycardia, what's a sinus block, sinus arrest. So let's begin with the important thing. I continue to say NSR, normal sinus rhythm. In order for us to have a, which if we were together in class, my guess is all of us would be in what we call normal sinus rhythm. So this means that there's everything is healthy looking. We call it a 1-to-1 ratio. 1 P wave to 1 QRS, right? That's healthy. That's what it should be. So 1-to-1 ratio, a P wave that's followed by a QRS. The PR interval should be normal. You know that is less than 0.20. The QRS should be normal, which is less than 0.10. This all should be positive in lead 2 and negative in AVF. So a positive P wave, a positive R wave. In leads 2 and AVR should be the opposite because remember AVR is that flipped upside down lead. So a positive lead 2, P wave and QRS, and a flipped negative P wave in AVR or R wave in AVR. The heart rate should not be less than 60 or 100 or higher because that would we'd then call it either bradycardia or tachycardia, and we want to have normal axis deviation, so positive lead 1 in AVF. The patient should be presenting with no symptoms. So here is a rhythm strip, right? That's one lead. It's showing you on the photo here a lead 2. We call this normal sinus rhythm because we have 1 P wave, right? You can see the P wave, 1 P wave for each QRS, and then a T, right? P, QRS, and T. I also am going to take a look at my R waves. They're nice and rhythmical looking. They're happening in a regular cadence. I do dark line method. So this R wave falls in a dark line, 300, 150, 100, 75. That's a great looking heart rate. So going through what we call normal sinus rhythm, this slide shows us normal sinus rhythm. If something's sinus bradycardic, it would be a heart rate less than 60. You already knew that. People that are non-symptomatic are usually between 50 and 59 beats a minute. This can happen with people in this class that are well-conditioned. So well-conditioned athletes commonly will have a heart rate less than 60. We call this non-symptomatic. We're not really concerned about this for trained aerobic athletes. However, if your grandma, sedentary mom, people that are not healthy have a heart rate low, then this can be very problematic. Symptomatic or marked reduced heart rate, lightheadedness, hypotension, syncope. What we see is decreased cardiac output from disease. There's usually some heart disease that's set in. They could have underlying arrhythms, myocardial infarction systems, beta blockers. However, if you're in this class and you're training, we call that asymptomatic, because you have a low heart rate because your heart is strong. But again, guys, don't be confused with bradycardic. For many times, it's not safe for people that are out of shape, deconditioned, excuse me, with risk factors to be bradycardic. So sinus bradycardia, very common among training. It's also very common as a result of someone who's on a medicine called a beta blocker. Even if a patient's not taking a beta blocker, the day of testing or training, heart rate's usually still going to be in the system. It's still going to be lower. Here is what bradycardic looks like, right? So we have a P wave and a QRS, right? Everything looks fine. What we see though, look at how delayed the heart rate is. This R interval is very delayed. So if we do the math on here, this one did the 1500 method. So we're counting how many boxes between this R wave and this R wave. We have 27. We do the division and we get 56. That would be bradycardic, right? So sinus bradycardic can happen with someone who we haven't learned about this, but we can be in an AV block, a bundle branch block, a hemi block. We're going to look at all of these blocks. Symptomatic bradycardic is not healthy. They're not getting blood flow, cardiac output, sick sinus syndrome. They may need medicine. They may need a pacemaker. The opposite to this is sinus tachycardia. Sinus tachycardia, right, is greater than 100. Usually we see this with people with decreased vagal tone or increased sympathetic tone. Many times they're asymptomatic, right? They don't have symptoms, but can reduce ventricular filling and cardiac output. It may precipitate maybe the beginning of some heart disease, beginning signs of someone being ischemic, not getting adequate blood flow. They may begin to get angina. So the heart is beginning to overwork. It's beginning to overcompensate, trying to get blood flow, right? Because usually heart disease. So angina symptoms happen a lot with ischemia, right? That word ischemia is lack of blood flow. They can have angina. They can have premature contractions, so heartbeats that are happening too quickly. Wall motion changes that you can see on the echocardiogram. So ischemia oftentimes can set in. I said the same thing with bradycardic, and it can happen with tachycardic. Either one are not ideal. Here's a photo of what tachycardia looks like. So what we're seeing again, I do see a P wave with a QRS, right? PQRST, PQRST. The difference here is everything's happening quicker, right? You see that these intervals are happening more frequently. So we do the math. You count those baby boxes. Do the division by 1500, or you can do the dark method, right? The dark line method. So let's go with this one as close to a dark line. So 300, 150, oh my gosh, just below 150, right? 120, this is what's tachycardic. So increased sympathetic tone, this could happen from bronchial dilators, caffeine, nicotine, cocaine, amphetamines, stress, anxiety, acute my MIs, right? So somebody having a heart attack, congestive heart failure, pulmonary embolism, body is in distress for different reasons. The treatment is focused on removing and correcting the underlying cause of what's causing the tachycardia. Something else can happen in the sinus area, and this is called sinus arrhythm. So it's irregular transmission of electrical activity between the atrium and the ventricles. So typically the heart rate should be between, we know, 60 and 99. RR intervals, however, become irregular. So I showed you, let me just go back to a photo, right? These RR intervals are happening regularly. If we do the count, they're very, very regular. Now with sinus arrhythm, we have a lot of irregularity. So here is an example of a sinus arrhythm. So by fast glance, I'm sure your eyeballs jumped maybe right over here, but let's look. We've got very regular R waves, and then now all of a sudden it gets irregular. So we have a change, right? So we have sinus arrhythm that's happening. So patients can be asymptomatic. We can see this exaggerated between respirations and rate of breath, people that become very exhausted in exercise, people with restrictive pulmonary disease or obstructive pulmonary disease. Not sure if you've learned a little bit about restrictive and obstructive. There's different conditions that set in with the lungs. Oftentimes, sinus arrhythmia is benign, not a big issue, no big issue needed, but it's something you want to just note. Another thing is called sinoatrial or sinus block or pause or an arrest. This is where the SA node to the atrium is not communicating. So there's a delay, a pause in the EKG. Oftentimes people are going to present being dizzy, lack of awareness, in and out of consciousness. It can oftentimes occur during sleep as well. So before this sinoatrial sinus block, the RR intervals are consistent, and then usually you have a delay or a block. So a sinus block longer than the direct multiples of the R to R interval. So variable, usually greater than 2 R to R intervals. I think it makes most sense when I'm talking about this for you to see it. So here is what we call a sinus block. So these X's, right, is where you should see a contraction, but you see this block, this pause, this delay. That's what we call, and then it comes back again, right? So we're missing a couple of contractions. Here we're missing 3 contractions. So this sinus block is not good, right? It's being caused by some other underlying problem. This is a sinus pause. So it's a delay is really what you're seeing here. So the arter intervals are, as you see, very delayed. Here in this photo, we have what we call sinus arrest. Sinus arrest is longer than the sinus pause. So again, we have kind of this big delay in contractions. So what could cause this is lack of blood flow. The SA node up in the atrium is diseased. Vagal tone, extreme vagal tone. Somebody could have something called digitalis, which they're on a medication that's causing this. It can also be caused with aging over time. So sinus block, atropine is the medicine. It's also called sick sinus syndrome, SSS, sick sinus syndrome. Another thing that can happen is asystole, right? The flat line, no electrical activity, no cardiac cycle. You don't see any P, you see no QRS, you see no T wave. So first we need to confirm asystole is happening in all the leads and not just maybe one electrode fell off. If you see asystole, we want to begin cardiac CPR. If you're in a hospital, they're going to begin a line, an IV line. They're going to shoot in some epinephrine, some epi. They're going to continue CPR for 10 seconds. If you've got access to cardioversion, we're going to cardiovert. So students love when asystole is on a quiz because I think you know asystole, right? That nice long flat line. So asystole, cardiac arrest. So we're doing chest compressions, CPR. If you have an external defibrillator, we're going to shock them. If you're in a cardiac rehab setting in a hospital, we're going to begin an IV and do some epinephrine. So asystole usually happens because heart is deconditioned. Usually they're first going to go into some ventricle rhythms. We'll look at those. You see VFib. Usually VFib will go into VTAC. And then from that, usually you end up with asystole. So this week, you're going to look through these slides and you're going to come up with some really brilliant questions, either true, false, or multiple choice. My goal is to recycle some of these good ones on the next upcoming quiz. Your job is to post the discussion question by Wednesday. Everyone else in the class is getting on and answering. Right or wrong, it's okay. Go in and say your answer and remember by the end of the week on Sunday, please post your correct answer. And we will use the discussion board as a way to study when we go to take quiz 2.